Alright, this is going to be airway management and ventilation, part 6. Topics we're going to discuss here are going to be ventilation, types of ventilators, and then last but not least, documentation. Ventilation. Mechanical ventilation is used for many reasons. Apnea, upper airway protection, relief of upper airway obstruction, improved pulmonary hygiene, refractory cardiogenic pulmonary edema. So like if the pulmonary edema is not going away, we're going to probably intubate them and provide some ventilation. Respiratory failure, anticipated respiratory deterioration, myocardial ischemia whenever we need to change atmospheric conditions, and then last but not least, hypoxemia. Automatic transport ventilators really aren't what we would consider a critical care ventilator. They're designed for convenience and easy use. They're lightweight and durable, runoff of the portable oxygen supply, and they pretty much control the ventilatory rate, tidal volume, and then they have a couple of different ventilation modes. As far as the control on them, they have a pop-off valve instead of like a pressure trigger. Hindrance in the case where you want to increase the airway pressures, and examples of this are going to be ARDS or cardiogenic pulmonary edema, to wherever you have fluid in the alveolar sac. Types of ventilators. Negative pressure ventilators. Iron lung was probably our first one. We do not use these in critical care anymore. This would take up most of the space on our units, and or if we were using them on an aircraft, there's just no room for these. Positive pressure ventilators, whenever we talk about those, we have pressure cycled and we have volume cycled in positive pressure ventilators. And these are just general types of ventilators as we're talking about these. A pressure cycled ventilator, inspiratory flow is delivered until a specific pressure is reached. So in a pressure cycle ventilator, you have a setting for when the airway pressure gets to this, please stop the initiation. The advantages of these is they're inexpensive, they're compact and fairly mobile, they can operate on compressed oxygen. Some disadvantages of them: tidal volume delivered can vary based on lung compliance. So like if the lungs weren't as compliant as they should be, then your pressure would increase, and that would cause the cycle to trigger early. Can create an increase in thoracic pressure, requires endotracheal intubation. Volume cycled, inspiratory flow delivered until predetermined volume is delivered. So on these here, we'll set a specific volume, and then the volume itself is going to be, whenever that volume is reached, then the respiration will stop. Advantages of this: accurately deliver a set of volume regardless of the pressure. And the disadvantages of this is it increases endothoracic pressure, which can actually give you a pneumothorax if you're not watching for it. Requires endotracheal intubation. Control type of ventilators. And a control, whenever we're looking at control, and these are terms here that are going to be associated with ventilatory settings. Control is how the ventilator knows how much airflow to deliver to your patient. And these are kind of in the modes of operation. And there are 3 different types here when we're talking about various types of control in ventilator models. Determines how much flow the ventilator delivers. There is volume control. The volume is set and the pressures are variable. So as the pressure, you can set the pressure to whatever. A tidal volume is a weight-based measurement, and we'll talk about that here in just a little while. And then we have pressure control. Pressure is set and the volume is variable. So this would be off of airway pressure, or a pressure controlled ventilator. And then we have a dual control. Volume is set and the limits are placed on pressure. So this is what most of the current critical care ventilatory management or ventilators use, is they use dual control, where we can both adjust the tidal volume and we can also adjust the amount of pressure. It can be off a pressure trigger. If the airway pressure exceeds 30 centimeters of water pressure, then the inspiratory phase stops. Support, also a term. This is going to be on ventilator modes, and this would be if we wanted to change the type of ventilatory support that we're giving our patient. We have a control mode. Ventilator delivers a preset tidal volume regardless of the patient's effort, and this is going to be absolutely control of the patient's ventilations. And then we have support mode. Ventilator detects inspiratory effort by the patient and supplies an assisting pressure during inspiration. Assisting pressure is adjustable, and this is determined by the operator. Ventilation is terminated whenever the patient exhales. So as the airway pressure on this inspiratory cycle goes in, whenever it reaches a certain point and the patient starts exhaling, then this ventilator is going to escape and allow for exhalation to occur. Cycling. In cycling, these are also terms as well, determines how the ventilator switches from inspiration to expiration. And we can do this if we have them completely paralyzed by a time cycle. Ventilator will deliver inspiration of predetermined time, flow cycle, which is ventilator switches when a predetermined pressure level is reached. So this is the amount of airflow that's going across there, and whenever that pressure is, or the back pressure, the lungs are full enough, the flow cycle would stop the respiration. And volume cycle. Ventilator switches when predetermined tidal volume is reached. Now the problem with this one here, whenever we're talking about a volume cycle, is that if we are not watching the patient's lung compliance, we can get into problems here. We can actually cause barotrauma from the actual ventilator, or we can give them an acute lung injury from the ventilator as well. Triggering. Stimulus that begins with inspiration. And these are also terms. We have a time trigger. Ventilator is set for a number of breaths per minute, and that's where we'll probably put most patients at. And then we have a pressure trigger. Ventilator senses the patient's inspiratory effort, and this triggers the ventilation, senses a decrease in pressure. So as the patient initiates the respiration or provides negative pressure, this is going to trigger the ventilator. And then a flow trigger. Ventilator senses variations in gas flow through the ventilator circuit with the patient's inspiratory effort and triggers ventilation. And then we have breathing. Patient-initiated respirations causes the ventilator to cycle from inspiration. And then we have a mandatory triggering. Ventilation is controlled by a set respiratory rate. So if we apply a mandatory trigger somewhere in the patient's respiratory cycle over a minute, generally we can set these in like 5 per minute or 6 per minute. These mandatory ventilations are to assist the patient in opening up the alveolar sac. And then we have assisted. The ventilator will assist the patient's negative respirations. Spontaneous is another variation of this. No additional assistance is provided on inspiration, used with CPAP or BiPAP. So whenever we're in continuous positive airway pressure, or CPAP, or BiPAP mode, bilevel intermittent positive airway pressure, or in either one of these modes, what happens is that the patient will trigger the respiration all by themselves, and the machine will kind of go into assistance mode. In the CPAP mode, it's continuously providing airway pressure. In the BiPAP mode, it doesn't provide pressure until the patient initiates the ventilation. Ventilatory modes. Now, all of those were terms that were related to various types of ventilators. These are the ventilatory modes that most ventilators will actually have. And the first one we're going to talk about is assisted control, and provides full tidal volume at a preset rate. The patient can initiate the breath on their own. The ventilator will assist with full tidal volume, and this provides nearly complete rest to the ventilatory muscles. Assisted control can be used in patients who are conscious, sedated, or paralyzed. Now, a lot of questions arise that, wait a second, we're assisted here. How's this going to work on the patient that's paralyzed? We can set a specific respiratory rate that must be maintained. So in that case there, if a time has lapsed, then the ventilatory cycle will trigger. Can result in hyperventilation is one of the downfalls of this, which is low CO2 levels or respiratory alkalosis from flipping their gases. and can result in breath stacking, and this is going to be inspiratory expiratory. The inspiratory expiratory time, if a person has a reactive airway disease, their lungs are like the Roach Motel, and what that means is the air goes in, but due to bronchospasm or their respiratory disease, the air stays in there, and it takes a lot longer for them to exhale. So in these patients, we can stack respirations in the alveolar sacs because we did not allow for long enough time for exhalation to occur. And this is what assisted control mode looks like. As far as these graphs here that we're looking at, these are liters per minute. So how much actual volume of air that we're running through the body. And this is the amount of volume that's actually occurring in liters. So this is 750 milliliters. It's because we'll look at these in other ventilatory modes as well. And this is the amount of pressure in centimeters of water at the bottom. So each one of these graphs, and this is assisted control. If we'll notice that the actual ventilations are nice and rhythmic, they're timed, and this is either assisting the patient in what they're doing if we've applied pressure trigger, or it could take absolute control if we've set it to a specific rate. A synchronized intermittent mandatory ventilation, SIMV. SIMV, ventilator delivers preset tidal volume at a predetermined rate. If the patient initiates their own breath, the ventilator will not provide preset breath. So this one here is used generally to wean patients off of the ventilator. The ventilator does not support patient's breath with full tidal volume, often used to wean the patient off the ventilator. Respiratory fatigue and failure can develop if the rate is set too low. So whenever we're looking at this, we have to kind of attune this spontaneous intermittent ventilation with what the patient is actually doing. This would, so let's say if someone is post-pneumonia, this would help the patient in opening up their alveolar sacs so that they can actually get air and ventilation in there. Adjusted with a little bit of PEEP as well for positive end expiratory pressure. This would help a pneumonia patient quite nicely whenever you're trying to wean them off of the vent. And again, these here are the spontaneous intermittent ventilations, and this is the normal ventilatory cycle here. Pressure support. Ventilatory assistance, spontaneous patient breath to predetermined peak pressure. So what this is going to do is this is going to initiate pressure support or give them pressure to a certain specific level, whatever you set the ventilator at. Avoids asynchrony, so it avoids them being off sync between the patient and the ventilator. So if the patient does have some of their own respirations, this would be the mode to actually go into if we didn't want to knock them down. Cannot be used in patients who are comatose. So if they're completely out and they don't have their own respiratory drive, this is not, because this is going to be off of their initiation and will synchronize the ventilation with them. Heavily sedated or paralyzed patients. Respiratory fatigue and failure can occur if the pressure support is set too low, and that's because it will not initiate a ventilatory cycle. And this is pressure support. These might be spontaneous on here. This one was initiated by the patient. Pressure control. Pressure and respiratory rate are pretty much predetermined on pressure control. Ventilation delivered until predetermined pressure is reached. And can result in limited tidal volume because we're not really working them off of the volume here, we're working them off of the pressure. Can result in low minute ventilations, and this would be the amount of flow that occurs over their lung tissue in a minute's time. And this is pressure control. These are initiated by the patient. Positive end expiratory pressure, or PEEP. Application of 2.5 to 20 centimeters of water pressure at the end of expiration. And this pretty much prevents atelectasis or stiff lung tissue or collapsing of the alveolar sacs. However, by applying this expiratory pressure at the end of their ventilation, it can cause barotrauma because we can do air stacking in there or air trapping, and it can increase interthoracic pressure. Depending on what your patient's lung tissue condition is, this could give them a tension pneumothorax if not watched very carefully. This just shows PEEP. We got a nice amount of spike occurred in there. Tidal volume, nice peak end expiratory pressure. Airway pressure release ventilation, or APRV. Low-level CPAP with alternating high levels of CPAP allows for a higher tidal volume. So what this is going to do is this is going to give the patient kind of a rest break in between their CPAP cycles. And what this does is this provides a high amount of airway pressure, continuous airway pressure, and then the pressure will kind of wane off. And then during their next respiration cycle or respiratory cycle, it provides more positive pressure as well. It gives the patient kind of a break so that they don't feel like, sometimes whenever you place them on CPAP, they feel like they're kind of, they can't breathe. The air is actually pushing against them. But most of the time, if they'll concentrate and breathe, we can easily push pulmonary edema back into the interstitial spaces where it belongs due to the airway pressure. And this is what it kind of looks like on a graph here. The highs with the lows, release phase, highs with the lows, and the patient's ventilating in here. Spontaneous breath, spontaneous breath. These are timed. Another spontaneous breath. Pardon me. All right, mechanical ventilating parameters. Several controls are common to most ventilators. Required parameters vary depending on the patient's actual need. Mode. Desired mode varies with the patient. So SIMV and assisted control modes are adequate starting points for most patients. Assisted control is going to be more controlling. The spontaneous intermittent ventilation is generally used whenever we wean somebody off of there. Sensitivity. Assist mode, whenever we're in that. Inspiratory effort measured as a negative pressure, so whenever the patient initiates, the actual causes a negative pressure in the ventilatory circuit, and this is going to initiate the breath. And the common settings on this, whenever we're looking at sensitivity, is 1 to 2 centimeters of water. Minute ventilation. Minute ventilation equals tidal volume times the respiratory rate. And what this is going to do is this is going to give us milliliters, pardon me, milliliters or minute ventilation per minute. How much volume have we entered into the patient's lungs in a minute's time frame? And normally we ventilate someone at about 6 to 10 liters per minute. Not milliliters, liters. So this would be 6,000 to 10,000 milliliters per minute in an adult. And that's an adequate setting to set your minute ventilation on. Tidal volume. As far as tidal volume goes, it's pretty much the volume of each breath. Most people just figure it off of their body weight, which is kind of incorrect. Tidal volume equals alveolar air that you have plus the dead space, commonly between 5 and 15 milliliters per kilogram, and this is of ideal body weight. Now, a lot of people have a problem figuring ideal body weight. The ideal body weight in males is figured by their height in inches minus 60, and we multiply that by 2.3, and then we add 50 to it. Now that's going to be their ideal body weight. The same way with females, the actual formula changes a little bit. Height in inches minus 60 times, that's supposed to be a times there, times 2.3 plus 45.5. And the example, male who is 76 inches high, 76 minus 60, we start on this end of it, times 2.3 plus 50 is 86.8 kilograms of ideal body weight. So as long as we know what their ideal body weight is, we can adjust their tidal volume. Now, most of the time, whenever we look at tidal volume, we actually set it to the patient's overall weight. And that's kind of incorrect. AHA, American Heart Association, suggests that during cardiac arrest, that we should only ventilate to about 6 to 8 milliliters per kilogram. Now, the reason that is because the lower amount of volume that's actually in the lungs allows for better cardiac filling or ventricular filling during chest compressions. Respiratory rate, 8 to 12 breaths per minute. 20 breaths per minute is going to equal hyperventilation. A lot of times we don't control the actual ventilations that we're actually performing. A ventilation should actually occur, ventilation occurs 1001, 1002, 1003, 1004, 1005, 1006, and then another ventilation. Most of the times whenever we see ventilations occurring, everyone's a little excited and we get an overventilation, or we're actually hyperventilating. In chest compressions, whenever we're doing them, that's problematic. The more time that we have ventilation in the actual lung, the less cardiac output we actually have during chest compressions. Inspiratory-expiratory ratio. The normal setting is about 1 to 2. However, a tad of common sense should be used with this. If they have some kind of restrictive airway disease, COPD, emphysema, asthma, then we should probably allow for longer exhalation times. So 1 to 2 is a normal setting. 1 to 4 may be used in a COPD patient because they require more time to get the actual air out. We do not want respiratory or ventilatory stacking to occur. Flow rate is generally 40 to 80 liters per minute. It's commonly used. Patient with obstructive lung disease require higher flow rate. We might actually have to kick this up to 100. And this would be the amount of liters per minute that we're actually running over their lung tissue as far as the flow rate goes. This is also associated with our other settings, our tidal volume settings and our minute volume settings and so on. Inspired oxygen concentration, or the FiO2. Whenever we generally set this up, unless we know the patient's FiO2 settings, we set it up at 100%. If we have blood gases available, then we should titrate our FiO2 to the blood gases. And this would take us probably the next 15-20 minutes to adjust them. Very simply, 50 to 60 would be an appropriate setting to try to wean somebody off. If they're still in a hypoxic event, though, please keep them at 100%. A SIGH. SIGH is a normal respiratory function. It pretty much helps prevent atelectasis. Whenever we do this, it helps open up the lung tissues a little more. 1.5 to 2 times the normal tidal volume. When this is about 10 to 15 times per hour, we should also apply heat and humidification. We don't want to chill them out too much. This can make them hypothermic if we're not paying attention to that. 37 degrees Celsius would be our setting, and we should apply 100% humidity. That's easier on the lung tissues whenever the actual gases are humidified. Alarms. A high pressure alarm, usually set to activate when the pressure exceeds 10 to 20 centimeters of water over the patient's peak inspiratory pressure. So whatever we set the peak inspiratory pressure on most monitors, if they're critical care, they'll have a high pressure alarm that you can set as well. Triggers include increased airway resistance. So let's say they have a developing tension pneumothorax, or they have a mucus plug that formed in one of their smaller airways or smaller bronchioles. Accumulation of secretions, kinking of the vent tubing can also occur, that can cause this to occur. Bronchospasm, the patient actually coughing. Decreased lung compliance would be also ARDS, which ARDS is caused from the alveolar sac kind of removing itself from the basement membrane. In this little area here, we have a basement membrane that attaches this to a capillary, which about one red blood cell can fit through. The air's in here. So in ARDS, what we see is a thickening of this area here. Now what that causes is that causes us to have a decreased amount of oxygen transfer into the red blood cell area. It also will cause interstitial fluids to spill into the alveolar sac. So both of these decreases lung compliance. Pneumothorax, pop the lung, causes a shift. This side pressurizes more and more and more at each ventilation. Pulmonary edema, different cause, but same fluid in the lungs. And then pneumonia. Pneumonia can actually cause fluid in the lungs too from damage to the alveolar sac. Thick viscous mucus and exudate from the actual immune system trying to fight off the bacteria. Any of these can initiate a high pressure alarm. Low exhaled volume, usually set to activate if the tidal volume falls 50 to 100 milliliters below the volume or set volume. Triggers includes disconnection of the vent circuit, low exhaled volume, ET cuff leak, to where instead of actually ventilating the patient, it's ventilating the oropharynx. Apnea. Apnea alarm sounds if the patient does not take a breath, especially if you have them on an SIMV mode or something like that. An apnea alarm is going to be something that you're going to need to set in a predetermined amount of time. So we give them enough time. If they don't breathe on their own, then the apnea alarm will sound. Low FiO2. Alarm sounds if FiO2 decreases to a predetermined level. Triggers include disconnection from the oxygen tubing. Most of our transport ventilators actually run on our oxygen. Some of the newer models mix air and oxygen together so that you can adjust their FiO2 from just an import area. You don't have to actually have air. If you do have a critical care monitor with an air source and an oxygen source, then if one of those become disconnected, it may trigger this alarm, it may trigger one of the previous alarms to where we have a low exhaled volume. That would probably be ventilatory circuits. So the low FiO2 triggers include disconnection from the oxygen tubing or depletion of the oxygen bottle. And usually that's pretty evident because that's what's driving the ventilatory cycles. Documentation. This is important for many reasons. Accurate record of all events that occur to the patient. So if there's a transition of care from one place to another, other healthcare providers can kind of look back through your documentation and figure out what happened or adjust treatment accordingly. It also helps in aiding a QA and a QI process. So if we've learned something from this, that it can be passed on to future generations and protects against any kind of legal claims. The patient wasn't intubated for this entire time. Well, yes, they were. I had good capnographic waveform through the entire time. We don't get CO2 from anything else but the lung tissue. Over documentation is pretty much more desirable than under documentation. And this is going to end part 6. Again, if you have any questions, please feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smith@imsa.net. Thank you.